Welcome back to the latest episode of Taking Charge of My Cancer, and it's an honor to have as my guest an amazing surgeon, Dr. Susan Klimberg. Dr. Klimberg is a professor and the division chief of surgical oncology and colorectal surgery in the Department of Surgery at the University of Texas Medical Branch, UTMB. She is a board certified and fellowship trained surgeon with 3 decades of experience in breast surgical oncology. Dr. Klimberg holds the Courtney Thousand Jr. Distinguished Chair in General Surgery and is a clinical director at the UTMB Cancer Center and medical director of the Breast Cancer Service Line. Dr. Klimberg earned her medical degree with honors in 1984 here at the University of Florida in Orlando, Florida.
Yay.
Yes. She remained at UF to complete her general surgery internship, and she went and completed her breast disease fellowship at the University of Arkansas for Medical Science in Little Rock, Arkansas. She joined UTMB in 2017, and at the same year, she earned her PhD in clinical and translational science from the University of Arkansas. In her career, she has pioneered innovative breast cancer treatment methods and holds several patents in surgical treatment methods. She had authored over 260 publications in peer-reviewed journals and 49 book chapters in surgical textbooks, as well as served as an editor of 13 surgical textbooks. She is the chair of the Oncoplasty Breast Skills course of the American College of Cancer, held over 30 editorial board positions for surgical journals and publications, and had won over 75 awards in teaching, research, and clinical care, and is the past president of 3 major American surgical organizations. Her clinical interests include prevention of lymphedema using axillary reverse mapping, the ARM technique, netless breast surgery, minimal invasive breast surgery, treatment of breast cancer with radiofrequency ablation, diagnosis of breast cancer with TERS, high risk management, breast pain, and chest wall pain after surgery. So I can keep going on and on. You are just amazing. And thank you so much for being here with me today.
A pleasure to be back, at least electronically, to my old alma mater.
Exactly, exactly. So, Dr. Klimber, you wanted to tell us a little bit your role of mission and were you always planning to do this?
No, not always. I wanted to be an opera singer, but decided that I could do that on the side, which I really can't. I can't even sing anymore. But then I decided, well, I'm going to do uh, medical. And then when first time I stepped in the OR operating room, I knew that's what I want to do.
That's amazing. Why breast?
Well, because there's a need. It's a great profession because there's a need for patients psychologically that I think I can fulfill, and technique wise, at the time I started, there was a big need for better ways to diagnose breast cancer, better ways to treat breast cancer surgically, and better ways to prevent the aftermath of breast cancer and the side effects of the treatments of breast cancer. So that's one thing, and it's a lot of artistry and plastic surgery within it. I'm an oncoplastic surgeon, so we can make the cosmetic result a lot better for patients. So it had a little bit of everything in it.
Well, I'm so glad that you are in this earth meant to do what you do, because thanks to you, we are able to do this, the arm trial and all the axillary mapping. Would you want to tell our audience a little bit about how was that, a little story behind? How did you come up with that idea and all the amazing transformation that this has been going on with the, breast surgery?
Well, I was involved with the initial trials on sentinel lymph node, and I was a core trainer for one of the national trials, and we went around the country teaching surgeons how to do sentinel lymph node. And that was at a time when it was brand new, and so we were teaching people sentinel lymph node, and then it was on a trial where we did sentinel lymph node followed by an axillary node dissection. And so I would watch them, I'd teach them how to do the sentinel lymph node, and it was a very exacting way that we taught them how to do it. And then I would watch them do an axillary node dissection. And one of the things that was obvious is that nobody did it the same way, even though in the textbook it's this border to that border to this border to that border, and it's very exact how it's written up, but nobody did it the same way. So if you look at all the randomized trials where they compared sentinel lymph node to axillary node dissection, they range for axillary node dissection, the lymphedema ranges from 7 to 77%. 7% lymphedema, and this surgeon gets 77. They're not doing the same operation. And it was all kinds of ranges in between. And at that, later on, when they did the same thing with sentinel lymph node, it ranged from 0 to 13%. So they're not doing it the same way. So I said, we need to better, rather than quit doing axillary surgery, we need to have a better way of doing it. And so we thought, what we want to preserve is the lymphatics from the arm, so let's map those instead of mapping what's coming from the breast, or not instead of, but in addition to, try to do that, rather split mapping. So I map what I want to take and I map what I don't want to take, and then when we're there looking at them, we can tell what we want and what we don't want to. And if you a certain percent of the time they coalesce, they're the same, and then we put them back together, and that's how all of this mapping and putting back together and bypassing all started.
Okay,
So
well,
then there was 100 different ways to do that.
Well, and then we have the fortune to have Dr. Singhol here, plastic surgeon, out of Beth Israel now. Like what? Man, that has been like maybe 10 years when we started doing lympha, right at the time of mastectomy, and really, brought this concept. And then he left, and then Dr. Spiegel ended up learning and doing that. And now it's our standard of care, which I'm really super proud of it, because really the amount of lymphedema patients that we see and we have a surveillance program is really not that much at all. Like, has been so great that
and if you get it, it's not that much.
Yeah.
It's much less than the massive lymphedema you used to see.
Exactly. So we're happy for that. What good resources would you advise patients to look into to educate themselves when they try to make, when they go have diagnosed breast cancer and they're looking for the surgeon and not too sure, still, unfortunately, some surgeons who are still doing axillary dissection. So what type of resources would you advise the patients to look into it to help them?
Well, some patients need to do axillary node dissection.
Yeah.
So it's even more important to do arm and nose, but the real crime is on a sentinel lymph node, where getting lymphedema when you had negative loads is the real crime. And so what part of the arm procedure that people don't think about, and we publish about, is to put the lymphatics of the sentinel lymph node back together, because many people just leave those. And in the major trials, it's 5 to 8% of lymphedema, and that's even more important. And just as many people, because so many more people are getting sentinel lymph node, just as many people get lymphedema from a negative sentinel lymph node as an axillary node dissection. So I think we need to do it on everybody. And so Komen.org is a good website, and there's Beth Israel has nice websites. But finding a doctor, I wrote a paper a long time ago for it was a presidential address actually, and it was treatment by chance. So meaning that you can go to one doctor and they both have the same credentials, and you'll get one recommendation versus you go down the street, you might get another one. So it's always good to get a second opinion. It's always good to know what is possible. And so a little bit of study will tell you what's possible. Komen.org is a good one. Breastcancer.org is a good one. So there's lots and lots and lots of information on the internet. Of course, you can get the I don't have it with me here, but right here it is. You can get the Bland and Copeland, the breast. Oh, I'm sorry,
Here
the
we go.
breast. And so that's named for our former chairman and vice chairman.
Oh,
And
wow. That's great.
that it's a book. I'm the lead editor on that book, but it was just renamed for Bland and Copeland, who obviously are great University of Florida former chairman and vice chairman.
Okay, great. Thank you for that info. Is any other like 3 valuable tips for patients who are experiencing right now breast cancer?
Oh, well, if you've just gotten it, it doesn't hurt ever to get a second opinion. It doesn't hurt, and I think the number one thing I would say to a patient is write all your questions down, because when you go to the doctor, you get nervous and you just don't ask all the things you were thinking of. So my patients, they'll come in with a list of questions, and I'll write the answers right on the sheet. The other thing is we provide, when our patients come in, we provide them with a recorder so that they can record the whole session. You can also record it on your phone, and just ask your doctor. I mean, they won't mind. You want to we want you to hear the message, and a lot of times when you hear cancer, you shut down and you don't hear. It's good to bring somebody with you with a second pair of ears, but also record it, and you can listen to it as many times as you need to. Have the doctor write down what they're talking about, what they're suggesting, and then there's also all kinds of tutorials on the web.
Yeah, that's a very good idea. So glad that's very practical. Even though phones are great, but it's really a great idea for you guys to be able to give a recording to a patient. So, because not everybody at this time, believe it or not, is that savvy with cell phones, or perhaps they don't have a smartphone, right? Occasionally. Um, what is a common questions that usually patients, when they come to you, you are kind of like first line, right? They find something mammogram and they go to the breast surgeon. So usually you guys are like first line there. So what is something that the patients tend to really ask you about, their care?
Well, they just don't, I would say they want to know about cancer and how it works. And then they can make some decisions about what they want. And so I would usually start with that cancer is really like a computer. You can have a computer not hooked up to the internet, which that's a certain type of cancer, ductal carcinoma in situ, where you just have to take out the computer. You don't need to do lymph nodes. You don't need to do scan the rest of the body. You can take care of things at the time. And plus with DCIS, the survival is 98, 99%. You can't make a wrong choice about what kind of surgery you want. And then it's really a matter of making a choice that is right for you. And everything's equal. And a trite example is if you go to the ice cream store, it's all great ice cream, but you might like chocolate. I might like pistachio. It's whatever's best for you. It's a trite example, but it brings home what I'm trying to say. Now back to the computer analogy. If your computer's hooked up to the internet, then it can spread. And you, just like on the computer, a cancer can spread just like on the computer, that you can send an email. And we know the first place it might send it is the lymph node, and so that's why we check lymph nodes. But if your internet connection's not very good, you're less likely to send something, and that goes to the why we check genetic information on the tumor in terms of genomics. And so we'll do an oncotype or a mammoprint or whatever you want to do, but some type of genomics to tell us about the tumor and its ability to spread. And that's why if you have a weak internet connection on the computer or a low oncotype or mammoprint, et cetera, on the tumor itself, then you don't need to do much. You don't need to do chemotherapy if you have a weak, low oncotype, a weak internet connection, because it's unlikely that it's spread. You can check the lymph node, but I mean, even outside that to the rest of the body. But if you have a high one, if you have a great internet connection, and you have a high oncotype, for example, then we know it's really has an increased chance of spreading, and that's when we would add chemotherapy and do a little bit more. So it's just a matter of really understanding, and I use a lot of analogies to try and understand so the patient understands what's going on and what might occur and what can occur, and really what their chances are. Because by and large, patients really don't have a good understanding of numerology. So I try to, if they want to hear percentages, I give them percentages. But you really just need to really understand a little bit better about what their chances are in real terms.
I love that analogy, Dr. Klimberg. That's so great. Sometimes that's what happened, right? Sometimes even if you have the greatest knowledge, when you get diagnosed with cancer, no matter what it is, everything just shuts down, right? The first thought is, man, I'm gonna die, and who's gonna take care of my family or my kids or my elderly parents, whatever it is.
Right.
Then no matter what, knowledge you have, or if you're in a healthcare system, sometimes it's like you just blank. So that's a great analogy. I really love it. So may have to.
But also another thing for, I mean, if you have medical people or even lay people, it's a good idea to find out what the patient does and try to use an analogy that's more relevant to them. Pretty much people can understand the computer because everybody uses it, but if I need to talk to my husband, I talk about fishing. I make a fishing analogy. So whatever the patient does, you talk in the language that they're most likely to understand.
Yeah, that was great. Um, how about any book recommendations for the audience, from like to understand a little bit, like, more Lyme words, to understand a little bit more about their cancer, or just help them to just go through this, mental stress or physical stress going through all this diagnose, anything that you have in mind?
Well, I'm not, we're writing a book now based on analogies because I don't think there are a lot of good books out there that really help. Susan Love, God rest her soul, had a book, but I think it was a little too technical, maybe. Then Monica Morrow has a book called Breast Cancer for Dummies. I don't really like the title, but that's of that genre, but nothing recent. Um, the breast book that I just showed you, that's a lot more technical. And the other big need, Dr. Lee Newmeyer wrote one, really for patients who have children and trying to explain breast cancer diagnosis to the children. Lee Newmeyer, she's at University of Florida, Jacksonville.
Oh, I didn't know that. How about
You should interview her.
Yes, that's a very good idea. All right, thank you for that info. How about any podcast?
Yeah, there's lots of podcasts. I couldn't really, I mean, you can go to YouTube and put in, breast or whatever you're looking for. You get lots of podcasts that way. Just YouTube is a great source.
Okay, all right. So nothing in particular. Great. How about any painful situation through your journey? If you can just kind of like, tell us a little bit, was something that really impact you through all these years, or like really make you a different person, different physicians, whatever happened either from you on your career or just life that you would like to share?
I guess so. I've been very blessed in my life, so I don't. Uh, the only thing that's made me a different person, I think, is having children. I have two beautiful girls, super people. One thing I would like to talk about is, we've developed I think part of the problem for breast cancer is people, especially after the pandemic, people get diagnosed later. And we're seeing that after post-pandemic, that people come in with bigger tumors, etc. I developed a test that you can get on the internet, where we diagnose breast cancer from tears. And so you can go on the internet. It's called Auria, Auria, and tears. And we send you a kit, and then you can. It's like it uses a Shermer strip, like the eye doctor uses to collect the tears. You send it back, and we can give you your risk of having a breast cancer at that point. We're not trying to get rid of mammography. We need mammography, but to date, only 40 to 60% of people do regular mammograms. Even if they've had breast cancer, only about 50% of people get mammograms
Oh, wow.
past 5 years. That's incredible. You've
Wow.
had breast cancer and you're still not getting your mammograms. So this is a really painless way of doing it. And if you've had breast cancer, I recommend people, because there's nothing in the recurrence space. So there's a big need in that area. And so we're doing studies now to show that it works for recurrences as well, which there's no reason to think it wouldn't. So you can diagnose it early, you can use it for recurrence, and you just order the kit and they'll send it to you. You can do it in the space of your own home.
Wow. What is it that you, from the more technical standpoint, what are you guys looking into that? DNA?
There's three proteins that all together give us a almost 90% sensitivity and specificity.
Oh, wow. That's amazing. That's so, it's a lot of, has been a little bit more of controversy about, I've been listening a little bit more over a couple of physicians who are doing functional medicine, and it's some controversy with like the amount of radiation that sometimes mammogram can give you. And
Only in the younger years, if you're less than 40, and that's why they don't want to do mammograms early, because if you're young, mammograms could give you enough radiation that it might make a difference.
So,
But 40 and above, recommendations even from the U.S. task force are 40 and above, although they recommended every other year, every other places every year.
yeah.
But even if we could get it every other year, we'd take it, because we want people getting their mammograms, of course. But if you're not willing to do that, go just cry a little. I know somebody can make you cry.
Yes. No, that's amazing. That's a really good thing. I'm wondering if Dr. Spiegel knows about it. I need to tell her all about that. So I'm like,
Oh, I'm surely she knows about it.
yeah. That would be like, why?
We're very good friends.
Yeah, I wonder why we are not implemented it here. This is the first time I hear about it. So wondering.
Right here on your podcast.
Yeah.
Florida.
Yeah. I'm gonna try to do that. That's for sure. How can people find you?
Find me?
Yes. I will put some of in the show notes, but we just tell us like where are you located?
Oh, I'm at the University of Texas Medical Branch. I also have an appointment at MD Anderson, Houston. And so I'm in Galveston, Florida. I forgot, not really, Galveston, Texas.
Got you. It's the links that you have with Florida, right? Is any one question you wish I would have asked you that you would like have answered. Anything else you would like to
Well,
add?
the only other thing I would want to talk about is I developed a technique called FIND, a fluoroscopic interoperative node or neoplasia detection, FIND.
Mhm.
And what that does is, you know, when you get a biopsy, they put a little marker or clip there. And at our institution, we use clips that I can see by fluoro. So once you place a clip after the biopsy, you don't need any other localization method, not a needle loc, not another clip. And we've shown that my positive margin rate is like 3%.
Wow.
Needle loc at our institution is 16%. Uh, a, some people use a radar or radio frequency clip to place, and they use special equipment, and that's 12%. So, and you know, but the idea is not to have any more painful procedures once you get a diagnosis pre-op. And
Mhm.
they'll put a needle in and take you to the operating room, or they'll put another clip in or another marker. But we've shown that those aren't we've shown that the second marker moves enough that it causes more positive margins. In other words, when I say positive margins, we didn't get all the tumor out at the first surgery.
Mhm.
So, and nobody wants to hear they didn't get out of the tumor. The patient doesn't really want to hear it for sure. And the
Yeah.
doctor, oh, we just cringe if we hear that. It's terrible.
Mhm.
So we want to get as painless a uh, journey for the patient as possible. So that's where it starts. Try not to try not to get, try to get that tumor out all at once. And so this procedure allows us to do it and allows us to choose the how big we want to make the tumor. And so that's at the tumor resection. And so that's called FIND, and it just uses fluoroscopic. And the reason that's so good is, most surgeries for breasts are not done at institutions like Dr. Spiegel and I uh, are at. They're done out in the rural areas, and so this is a technique that even a rural surgeon can use because every surgeon knows how to use fluoro.
Okay.
So I think that's really important for the patient to ask, how are you gonna localize my tumor?
That's very good because you're right. Sometimes when I see these patients pre-op and we see at least 99% of the patients for our surveillance program before surgery, to just kind of have some baselines for circumferential bioimpedance to detect early stages of lymphedema, and just really go over a lot of the education to help them navigate through this. And a lot of them, yeah, when they come to us, it's like, no, I'm really sorry because the biopsy, or they develop an hematoma because the needle biopsy and those kind of things. So it's nice to see other alternatives as well for them.
Great.
Um, do you refer a lot to physical therapy? You have a lot of like rehab involved in your program.
No.
Okay, any reason why?
Well, I mean, if they have lymphedema, I'll refer them, but well, glad you asked that. Most most commonly, what patients get referred for is pain, inability to move their arm, not necessarily lymphedema. So we have a very low lymphedema rate. So no, I don't really refer. And then I do trigger point injections for frozen shoulder
Mhm.
or pain. And I have a big breast pain practice that I do trigger points for successfully. We've written about this, and I don't have anybody that can't raise their arm up, even years after if I see them from somewhere else. We do a scapulothoracic injection. You have bursa that sit right underneath the shoulder blade, and that's what you move your arm on. And if they become inflamed, which can happen right at the time of surgery, then the patient has trouble raising their arm up. So I do an injection. It's in the back, underneath the scapula, the shoulder blade. And we put a mix of local lidocaine, marcaine, and a little bit of steroid. And then it's amazing, within 15 minutes, they can raise their arm right up. Usually that's all it takes. We use heat on the back there too. If it's minor, you can just use heat. And I use Aleve or Tylenol. I like to use Aleve since it's 12 hours and they can remember to take it. And I have them do that after, just to get that inflammation, continue to get that inflammation out of the shoulder blade. And the interesting thing, this is also causes breast pain and chest wall pain after surgery. So breast pain before just walking in the door, because the bursa sit right on the nerves that supply underneath the arm and the chest wall. So I can do that for breast pain and get relief.
Okay.
People don't believe this, but the patients do.
Yeah, no, I believe you, because we do something very similar, but not with shots, but we do it with doing myofascial release and trigger point release and using other manual therapy techniques and help with the scapula mobility, humeral joint mobility, rib cage mobility, to try to avoid that. So yeah, so perhaps that's something that you kind of start looking into, kind of work together with rehab. I think the sooner these patients start moving and go over the fear that movement is okay and is not going to create more harm, the better they do with their mobility and their shoulder and their pain. So I think that we don't see as much of that because we get to move. We see them 2 weeks post-op, so we get them moving.
Everybody?
For everybody. Yep.
Really?
Yep, everybody. So I think that we really help a lot on the, like I say, it's not just from the functional standpoint, but really managing their scar, working on what's coming next, right? A lot of these patients are going to have to go through chemo or radiation. So we see them throughout all those stages. So if they develop any radiation fibrosis, we kind of, work on it prior to it, working with them with an exercise program for cancer-related fatigue or any other, chemo induced neuropathy, whatever it is that they're developing, and we can really start working like right then to try to mitigate a lot of those symptoms. So we have really a lot of really nice, success outcomes to avoid those kind of situations. Again, we are going to have patients who develop, thoracic outlet syndrome or some kind of like breast neuropathy, things like that, that will need like pain management and injections and things like that, but we don't see that as often. And I think part of it is just because we really see them early on and hopefully help them to get through the movement. So yes,
Great.
so yes, we have really good outcomes with that.
Super.
Yeah, so that's awesome. Is anything else that you would like to add before we wrap up?
I think that's enough.
That has been great, Dr. Klimberg. Really, it's just really nice to see all these new things. You're always on top of new things and really appreciate, like I say, it has been amazing to see what the lymph techniques and all these, the arm trial gave us for us to, again, try not to see patients to develop lymphedema, but like I say, breast cancer is not just about lymphedema. This is just a minimum part of it. It's about like, quality of life and getting these patients back in where they need to get back and then just move on with their lives, right? So thank you for all the work you do and thank you for being here today.
Well, thank you for all the work you do, and I appreciate it, and taking care of Lisa as well. That's fantastic. I envy you being at University of Florida and admire all the work you're doing. Thank you, dearly, for having me.
Absolutely, Dr. Klimberg. You have a great rest of the afternoon and a great weekend.
All right. Bye-bye.
Bye.